Great. Hi everyone. So hopefully you can all hear me okay. But if there's any problems, please just let us know in the chat box. So my name is Marina. To introduce myself, I suppose would be a good start. And I'm the webinar coordinator for Evidence Synthesis Ireland. And we are delighted to welcome you all to this special summer stream of ESI webinars. So just by way of brief introduction, for those of you who may not know much about ESI, it includes Cochrane Ireland and is an all-Ireland initiative funded by the Health Research Board and the Research and Development Division of Public Health Agency in Northern Ireland. Our aim is to build evidence synthesis knowledge, awareness and capacity on the island of Ireland, and we have a number of key activities for achieving that aim, and one of those is our monthly webinar series on an evidence synthesis topic. So our presenters for today, we are absolutely delighted to have and are very close to home, are Dr. Linda Biesty and Dr. Catherine Houghton. So they're both on the line today, but I might just introduce them first. So Dr. Catherine Houghton is a senior lecturer in the School of Nursing and Midwifery in NUIG Galway. Catherine's research interests are primarily around qualitative research methodologies, qualitative evidence synthesis, and the integration of qualitative research in trials. Catherine is co-chair of Quest's Qualitative Research and Trials Centre in NUIG and Qualitative Evidence Synthesis Trainer for ESI. She's led and co-authored a number of qualitative syntheses, including the recently published Cochrane Rapid Review in response to COVID-19, which we'll be hearing about today. So Dr. Linda Biesty is a lecturer also at NUIG Galway, a midwife and qualitative researcher by training. Linda's research focuses largely in the fields of maternity care and knowledge translation. Her methodological areas of expertise are in evidence synthesis, qualitative research and trial methodology, and core outcome development. She's the co-lead for qualitative synthesis stream within ESI and a faculty member of ESI and provides training on Cochrane systematic reviews. So today in this webinar, Catherine and Linda will describe their very recent experience of undertaking a rapid QES during and response to the COVID-19 pandemic. So the review featured among the initial suite of Cochrane COVID rapid reviews as Cochrane's first QES. So a summary of the review process, key findings and dissemination will be provided, and the presenters will use a reflexive approach to talk about the importance of the team and the methodological decisions made during the process. So they'll explore some of the challenges, and of course, as is in the title, we'll hear about the balance of finding rigor with speed and maintaining also transparency in their work. So just to say that we'll have some time for questions at the end, so please do feel free to type your questions in the Q&A box as we go along, and we will make a recording of this presentation available on the website as well. So enough for me, I'm going to mute myself now, and I'll hand over to Linda and Catherine. Thank you so much to you both.
Thanks so much, Marina, and thanks for the introduction, and thanks for everybody who's tuned in for today's webinar. So just to begin, I don't think we need to introduce ourselves now, Linda. I think Marina did a better job than we could have done. And we're here presenting on behalf of an amazing team who you'll learn more about throughout the presentation. And again, we just want to thank Evidence Synthesis Ireland and Cochrane Ireland for their support, and also the Cochrane EPOC group around who you'll hear more about as well also. So this slide came with permission from Carla, the editor-in-chief of Cochrane, who presented last week another webinar. And we just thought it would be really helpful for people to see where we sat in this timeline. So as you can see, in week 2 of March, the WHO declared the pandemic, and the Cochrane started to begin to plan their response. We were invited in week 3 of March to conduct our review, which was considered a priority question at that time. So from there to publication, it was a turnaround of 23 days. And the first thing we needed to do at that point in week 3 was to gather a team of experts who could facilitate this review at the time.
So it looks slightly like a rogues gallery when I see it up on the big screen. But the way Catherine and I have decided to present this webinar today is to interchange her discussions about the review, how we did it, and what the findings of the review were, with also some reflexive pieces which will highlight to you some of the processes that we used, that we found useful, that perhaps we would give different consideration if the time were to come again. And I think we can do none of that without making reference to this team. Often, I think when you read of reviews, be they rapid or otherwise, you get a small snapshot into the team that put the review together. And I think we underestimate the importance, perhaps, and the attention that this deserves. As I said, a little bit of a rogues gallery here, and hopefully at some stage in the future, we'll get to have a picture of us all together and near each other. Very quickly, those of you in the qualitative evidence synthesis community will recognise the international experts that we were privileged to have on our team. We also had expert support from those with a background within the topic area in which this review sat. We had expert support from key information specialists that I think we could not have done without. We certainly couldn't have done any of the peer review processes that Catherine will talk about in relation to our search and that we will mention later on. One thing that we want to point out in relation to the process that we employed, and while we are incredibly aware that there are no set rules for how to do this, as all of you will know, we did something a little bit different to that of other rapid review teams that we know are presenting their work in relation to COVID. And by that I mean, whilst we had this team of support, and we'll talk about other supporters in a second, 4 of us worked as a core set within that team. Can 4 be a set? A core team. So Hannah, Pauline, myself and Catherine. And we worked through every stage of the review together. So we didn't divide methods in a parallel fashion that we've heard some other teams who are talking about their systematic review talk about. So perhaps where some screened while some moved on to the next stage. And we'll highlight as we go through the presentation why we feel this warrants consideration within the rapid qualitative evidence synthesis world, and maybe just why it worked for us at that moment in time.
Great, thank you, Linda. So this is when the clock started ticking. We were presented with a question: barriers and facilitators to healthcare workers' adherence with infection prevention and control guidelines for respiratory infectious diseases. The reason that I've underlined those 3 main concepts was because it did impact on the process throughout. These are very broad concepts: healthcare workers, infection prevention and control guidelines, and also respiratory infectious diseases. And that's, I suppose, primarily why the topic expertise, the information specialist expertise, as well as those of us who had experience with qualitative evidence synthesis, needed to really tease out what we meant by these concepts. And it sort of fed in throughout and was cause for a lot of discussion and debate at times as well. And had we, I suppose if we had more time to think about it, maybe a more refined question would have been easier. But we also wanted something that was relevant to COVID, but also relevant to other respiratory infectious diseases and other contexts and other times. So we were pleased really at the end that we had these broad concepts as well. So we registered the protocol, we gathered the team, as you saw in the previous slide, all the wonderful people that responded so quickly. And also we needed to find a home, and we were fortunate enough to have found our home in the Cochrane EPOC group, led by Simon Lewin, Claire Glenton, and through Claire's work on the review, she actually became a co-author because she was so integral to what we did, and they were so responsive as well in helping us through the process. And this is just to highlight, because again, with traditional Cochrane reviews, the protocol would have been published, but in the context of these COVID rapid reviews, it appears as an appendix in our full review that was published.
So I'm sorry, my camera seems to have been muted by the host there. So just to highlight the initial stage, the learning curve in relation to how we carried out the process that Catherine referred to there. And as well as finding a home within the EPOC group, we very quickly had to find a home as to where this rapid review sat and what guidance we drew from. And the Cochrane Rapid Review guidance, the intern guidance drawn up on the 23rd of March, did help us in this process. However, we had to be really mindful that we didn't privilege generic methods across all review types, and that we remained cognizant and mindful of the specifics that related to the qualitative evidence synthesis. So therefore, we had to, I don't want to use the word balance, I think marry is probably a better description of what we did. We had to marry the rapid review guidance with the protocol and review template that EPOC have provided in relation to qualitative evidence synthesis. And we also drew on some work led by Andrew Booth and colleagues, published by Healthcare Improvement Scotland, which provided a guide to conducting rapid qualitative evidence synthesis for health technology assessment. And our reflection on this point, while that seems like a lovely or linear process, it was a bit of a whirlwind. We wanted to become established within the protocol, to highlight the methods that we were going to prioritise, and perhaps some that we were going to compromise on. We'll talk more about this in a second within the time context that we had. And so we found it very important to have guidance to draw on, but yet we need to acknowledge that this was an iterative process that we had to work through because of the newness, if you like, of the methodology that we were using.
Sorry, I'm having difficulty moving the slides. Apologies for that. So the first point was developing the search strategy. As I've already mentioned, there was a challenge around the broadness of the concepts. So in order to make sure that we were articulating ourselves appropriately, we conducted a scoping search at this point, which really helped us to tease out those concepts and what they meant. And here we had the importance of our expertise, Andrew Booth, as those of you in the QES community will be very familiar with, and Mike Small, who works in NUIG Galway with us and was a co-author on the review. Cochrane, again, were very reactive at this point in terms of providing additional peer review from, well, Robin Featherstone, who helped to develop and refine the search strategy. And then it was also peer reviewed by Douglas Salzwedel in Canada as well. So we were very confident during this process that we had a robust and a sensitive or a specific rather search strategy.
So those of you who have engaged within our review will notice that we used one database, and we've gone around in circles in relation to our reflection here, and we're certainly aware that other teams who maybe have conducted systematic rapid reviews have made comment on the number of databases they have used. We do comment that we used one, but we also say this in the context that we know that for qualitative evidence synthesis that an exhaustive search may not be necessary. We did acknowledge that we didn't use the grade literature. Again, those of you within the QES community will probably have experience of the time frame that can be involved with sourcing and extracting data from the grey literature. So at this point in time, we made the decision not to include this within our rapid review and acknowledge the limitations that that does bring to our work. What we did do, and we think this is worth mentioning for teams who are maybe following in footsteps or considering similar work, we did an early scoping exercise while our formal search was being finalised and peer reviewed. And this scoping exercise involved screening title and abstract and citation chaining and tracing within key papers. We did this over a period of a weekend while we were, waiting for other work to follow suit and to be ready. And really, I don't think I can underestimate how important this was to our team, because it enabled us to have an early immersion and engagement with the literature. We probably will comment later on, but the 4 key core reviewers, this was not literature that they weren't necessarily familiar with. This was not their topic of expertise. So this early immersion in the literature really ensured that we refined our inclusion-exclusion criteria, we fine-tuned our searching skills, and really set us up for the more formal screening process that Catherine will refer to in a second.
I appreciate that people won't be able to see or may not be able to read the flow chart here, but it was just really to talk through our screening processes. Outside of I think we screened more than 1,500 outside of the official database search in those scoping and citation chaining exercises that Linda referred to. We screened 3,258 within Covidence. 72 full text articles were screened. From that, we identified 36 studies that met our inclusion criteria. At this point, we made a decision, and again, this is something that's much debated in qualitative evidence synthesis, to apply a sampling frame to give us a manageable number of studies that provided the depth of data that we needed, the relevance of the data that we needed, and make it more manageable in the time that we had. So we adopted the sampling frame that has been published by Heather Ames and colleagues in Cochrane Epoch, just to ensure that we had, as I said, that depth of data that we needed. But as well as this, we also needed to ensure representation from relevant respiratory infectious diseases, and for geographical spread as well. We didn't want to end up with lovely rich studies that were all conducted regarding tuberculosis, for example, which is a slightly different transmission. We needed to make sure that we had coronaviruses as well as other type of respiratory infectious diseases, while making sure we had that geographical spread and that depth of data that would help us with the review.
So in relation to the process that we employed, we probably reverted back to our comfort blanket in that we did double-blind screening at title and abstract and at full text stage. Now, obviously, different teams will decide on different methods, if they're going to double-blind screen a percentage or one-person screen and maybe check a percentage of those studies that have been excluded. This was just the method that worked for us, in that not only was it the method that we were comfortable with using because we'd used before, but we found it gave us reassurance because of the speed at which we were screening and the complexity that Catherine spoke of earlier on. For other qualitative evidence synthesis reviewers online, dallying at that screening phase seemed like a luxury. It was something that we wanted to ensure was done in a timely manner. We felt that double-blind screening assisted us with this. Any discussions that occurred in relation to any conflicts, they were occurring in real time. So I don't think we can underestimate the amount of time we spent online with each other, and probably video chats more than anything else. So we may have been screening for a few hours and then having real life conversations very close to that time in relation to any conflicts that may have occurred or any biases that we felt were coming through in our screening processes. And again, this provided us with the ability to engage early with the literature, but also to continue to engage with each other. So the 4 of us were constantly in contact during this phase. And just Catherine made reference earlier to the purposeful sampling technique we used. I think we were incredibly lucky to have had Claire Glimpton on our team, because Claire had experience of using this framework and developing this framework within a different context of another qualitative evidence synthesis. So again, bringing back to my mind on reflection the importance of reaching out to or choosing wisely those who are supporting your team through such a rapid process.
So just on to data extraction, again, just based on previous reviews that we would have been involved in, from my experience, I would have always used NVivo for extraction and synthesis. We were all housebound at that point, working on old computers and laptops and whatever was available to us. So that sort of software wasn't readily available for us. Again, based on experiences, Pauline Mescal set up Google Forms, having experience with this from Andrew Booth as well. And at this point, we just want to highlight that, so you can see, perhaps not read, but we use the extraction form to look at the different respiratory conditions, the populations, the type of guidelines, but also it allowed us to use our theoretical framework, which I'll explain in more detail when we talk about best fit framework synthesis. But it allowed us to begin that process of identifying the different themes under this theoretical framework, which was organized as organizational factors, environmental factors, and individual factors. So while we were doing our scoping search, we came across this framework, which was published in a Moore 2005 paper in response to SARS in Canada, and it just seemed fit for purpose at the time. With best fit framework synthesis, you can begin with a framework, but adapt it and use more thematic approaches during that process, which I'll talk about later. But it was really handy at this point in a timely fashion to extract the data that we would analyze further on.
And really just moving on from that, we really thought it important that we were all singing from the same song sheet, if you will. So using the Google Forms and using a pilot method to ensure that we were all extracting the same data in a similar manner, and we were all aligning the data with the framework or using additional domains if required, was really important, because it meant we could refine our data extraction form. We could then extract in a manner that was timely, whilst constantly checking in with each other over the course of the time. We employed a method where one reviewer extracted data and a second reviewer checked for accuracy and completeness. And again, there's no set rule in relation to doing this, but we felt that this gave us some confidence that we were extracting data that would meet the aims of our QES and also answer the questions of our review.
Thanks, Linda. Sorry, I don't know why it keeps doing that. Can everybody still see the screen? If there's any problems, please let me know. So the next stage was the assessment of methodological limitations that, again, the QES community would be familiar with. We used an adapted version of CASP, so slightly shorter, and two authors independently assessed and resolved disagreement with discussion and included other members of the team as per the EPOC guidelines. So you can see in the table below that we gave an overall assessment of each study in terms of major or minor or no concerns around the methodological limitations.
And again, our reflection point echoes really what Catherine has said, and I know there is debate in the literature in relation to this process. We again went with a similar independent screening and then cross-check. And whilst it contributed to the overall assessment in relation to the methodological limitations associated with the studies included this review, it also once again helped us with that immersion that contributed to our seamless movement that I know we're presenting in a linear process, but that movement across the different methods for the core group.
And on to synthesis. So we, again, as I said, we had identified the best fit framework synthesis approach because it's geared to produce these actionable messages by enriching existing theory. So it was fit for purpose in what we wanted to do with this review in terms of providing these actionable messages. Just to remind people that with best fit framework synthesis, there is, you use the identified framework, but you are open to possible additional thematic synthesis, identifying themes that may not have fit within the original framework. Actually, in our experience of using this particular framework, all of our findings fit within those three broad headings of organizational factors, environmental factors, and individual factors. On the left-hand side, you will see the original framework. But what as we engaged with the literature, as we developed our themes, and in consultation with our topic expertise, we actually realized that the term health and safety programs wasn't as meaningful for what we were presenting, and we changed that name to communication of IPC guidelines. You'll also see that we added an additional sub-theme under individual factors, which was around the discomfort of PPE or personal protective equipment, because it really featured a lot throughout the studies that we were reviewing and needed to be presented in our findings. And we identified 26 key findings within this framework that were used through, in all the dissemination in terms of developing the evidence summaries, and we applied great CERQUAL to those, which I'll talk about in a moment.
So this deductive approach, the best fit framework analysis that Catherine has just described to you, it is considered by its creators and by others suitable for rapid synthesis. And that really guided our decision and was one that we really were glad that we took. It allowed us to work individually as reviewers in relation to different parts, but then come together as a group. So the domains of the framework, we divided, if you will, then amongst our 4 reviewers, with each of us focusing on one of the domains as described by Catherine. I think we can easily say this was the most intensive part of the work, and definitely required that immersion in the data while still maintaining contact and communication across the other members of our group. So whilst immersed, we did ensure that we were constantly referring back to each other, reporting back to each other. And at this stage, our process became almost like mini presentation in the way we engaged online with each other, because it was important that we noted any overlap in the findings, that we mapped the range and the nature of the review concepts, and identified how the themes related but yet were distinguishable, and how they answered the questions. We do acknowledge as a limitation of this particular rapid evidence synthesis that we didn't conduct any subgroup analysis. And we are aware that obviously the importance of considering context and how the findings from different cultural contexts, different settings, different healthcare groups may be relevant to the overall findings of our work. We acknowledge this in our review and certainly in our reflections as a limitation of the rapid review process we engaged with, and something that we will be addressing.
Thanks, Linda. So then the assessment of confidence in our findings, we used grade CERQUAL. We had experience as a team of doing this already, and also having the support of the EPOC group was really important here. This is just to illustrate what this looked like. So we identified our 26 findings. We looked at the studies that contributed to those findings, and then looked at the 4 components of CERQUAL. So how coherent was the finding? How relevant were the studies contributing to that finding? The adequacy of the data that fed into those findings. And again, using our assessment of methodological limitations. Most of our findings we had moderate confidence in. And again, this is partially due to the broadness of the question. in terms of setting infectious disease type and the type of healthcare workers that were included in the studies. We had a couple of findings in which we had high confidence in, particularly around the discomfort of PPE comes to mind, and very few in which we had low confidence. So we were very happy with the level of confidence in which we had in those 26 findings. We did our assessments individually, but with continuous discussion and clarification of how we were making our assessments. So similar to the synthesis process, as Linda mentioned, we had these kind of online presentations almost, where we did a narrative, a walk through our thought processes, just to make sure that we were, again, all singing from the same song sheet.
And really one of the things that we have considered in retrospect, because we had agreed in the detail and because we had carried out this assessment to a very high standard, and we were incredibly diligent at this stage, but we didn't submit our evidence profiles. And now looking back and reflecting, we perhaps could have, because all the evidence was obviously there. It just was a matter of collating a table at a time when the clock was ticking. But we have, as you can note there, these have been submitted as the second stage and they're currently under editorial review. We were incredibly lucky, again, I keep talking about luck, but Claire Gentleton to do an informal peer review process in relation to our Great Circle assessment. And there's nothing like having one of the developers of a tool peer review your work to absolutely sharpen your presentation of your assessment. It's very useful.
And I think it was a point at which we were very grateful for that input, Linda, weren't we? Because it's kind of where you bare your soul, I think, in this process.
Absolutely.
So, on completion of the review, we were looking then to publication and dissemination. Again, an accelerated peer review process. You're talking about peer reviewers internationally sending their feedback in, within 48 hours, which was outstanding. And the editorial review and the copy editing, again, done at very high speed and required a lot of input from a lot of people in the Cochrane community and from the team ourselves. So we're so thankful for that. Dissemination required a lot of hard work behind the scenes, and I know Linda will talk about that in a minute. But Claire and the EPOC group were developing the evidence summaries as we were completing our write-up and, preparing the manuscript for submission and tidying up our tables. And again, so this was all happening in real time. Nikisha and Evidence Synthesis Ireland were working on developing an infographic. And, within days of submitting, Pauline on the core team presented at March for Science. We recorded podcasts, webinars, presentations for international groups. Mike Clark and Evidence Aid took on our review as well and promoted it. Cochrane Corner and Carla and the editor-in-chief webinar, we were invited to present on that. And again, there was some media interest here locally in Ireland as well. So it was fast and furious, and again, the support and the effort it took from people outside of the core team and outside of the review team was really important here. And this is just some examples. So we have the lovely infographic that Nikisha and Evidence Synthesis Ireland produced, which is a lovely visual for what our key messages were. And on the right-hand side, again, if you go onto the Cochrane website, you'll be able to access the evidence summary, which poses our findings as questions. And the reason we did this was we wanted to have a document that decision makers in healthcare could pick up and say, well, are we doing this? Are we prepared for this? Have we considered this? Just as a way of, rather than putting the focus on the responsibilities of the healthcare workers, but more at an organizational level, what can we do to help our healthcare workers adhere to these guidelines? What resources, what physical structures, what training, what can we do to help people work in these conditions? And it was really important to us that it was presented in that way. It's about supporting our healthcare workers in practice.
Firstly, before I begin, somebody has just texted me to say my commentary is dropping in and out. I apologise, my internet was flying this morning on trial. I'm afraid to touch anything if I go rebooting in case I lose everything. But please feel free to contact me if you have missed anything I said and you want to know further. So just in relation to the reflection on the path to publication and dissemination, I think when we look back, we definitely have used the phrase that we lived in a bubble during the bulk of that 2 weeks. We prepared a rapid qualitative evidence synthesis, but there were a machine of people around us preparing in a way that helped and supported us get the information that we could provide to the research community in as timely a way as possible. Catherine has made reference to some of them there. You will also see the acknowledgements as they appear on the actual review itself. We had 24-hour feedback from healthcare workers who looked at our evidence summary and provided feedback at a time when you can well imagine and they were fairly inundated with work supporting people within the healthcare community. I think it's worth considering for rapid peer review, translation and dissemination. We relied on many and we relied on many outside the team. So we are very aware of the dissemination that this review received, but also would like for other teams to consider the fact that in order for this to happen, the ongoing support was absolutely there and was needed.
Thanks, Linda. So just to summarise before we finish up, we were asked to talk about the balance between speed and rigour, and hopefully through our presentation you've been able to understand the decisions that we made and why. And just to kind of summarise what helped us do this in a speedy, rapid really nature, that was the invaluable support of EPOC and the wider Cochrane community, the availability of the topic and methodological experts on the team who again would reply to any of our queries immediately. The core team, as Linda has outlined, the amount of time that we spent with each other, the frequent and often online communication, the humour, the support and the goodwill. And one would imagine that we were sick of the sight of each other by the end of this, but actually we really missed each other when it was over, and we had to kind of find excuses to organise additional Zoom meetings, etc., so that we could chat and support each other in the aftermath as well. And the coordination of methods, so discussions were happening in real time. And we really, the idea that we were throwing everything at it, so where possible, parking other responsibilities and things that we needed to do so that we could really focus on this. In terms of rigour, again, hopefully the expertise of the team, we've been able to demonstrate that. The EPOC support and the template, so making sure that by following the EPOC guidelines we weren't cutting corners in an effort to be speedy, and that was really important to us, that we had that rigorous process ongoing, and staying close to the data throughout, as again Linda has outlined, the fact that the core team were involved in every stage. And just to highlight, I suppose, that hours don't equate with effort. This wasn't a 9-to-5 job by any means, and it involved working really hard and really fast. The substantial peer review gave us comfort in terms of peer reviewing the search strategy all the way through to the final review, which was, I think, 4 reviewers provided feedback for us. The option to submit the stage 2, so the evidence summary, the evidence profiles and the discussion, which are, as we said, under editorial review, just gave us a little bit of peace of mind that we didn't need to do those extra things, but they were always there. And as Linda said, we probably could have, but we just needed sort of some reprieve, I think, at this stage to help us get ourselves over the line. And we've talked about the clock, and the clock is still ticking. We have our stage 2, and there will be future updates to the review. which are important to acknowledge even in terms of things like the subgroup analyses that we would like to do in the future. And again, just a huge thank you to everybody who is involved. Thank you to you for tuning in today. But most importantly, thank you to our healthcare workers. They were our motive behind getting this done in a timely fashion. What we did was so minuscule and minor in comparison to that, and we do want to acknowledge you know, our feelings on that and our reflections towards the reason why we engaged with this review. I don't know, do you have anything else to add, Linda?
No, I think that's a lovely ending.
Thank you.